Good morning, everyone. I'm Paula Whitty, the Director of NEQOS, and welcome to our webinar about the Health Foundation funded Advancing Analytical Capability project that we have been undertaking. We're delighted that we've already got so many people able to join us this morning. Apologies that there will be too many of you to ask you all to introduce yourselves to each other, but hopefully everyone can see the full list of attendees on the right-hand side of your screen on the menu, which I'll talk about a little bit in a minute. I'll be chairing the webinar, and my colleague Valerie Corris, also pictured on the right-hand side here, will be keeping an eye on the chat room. You'll notice we've used photographs. We decided not to overcomplicate things by putting ourselves on a webcam, so this is our next best effort. Before we get started, I just want to explain how the webinar will work. We're planning to keep everyone on the call on mute, and we'll control your mic if we invite you to speak, and I'll more about that in a minute. We're recording the webinar and plan to make a copy of the webinar available on our website on the same page that you've already seen. We hope that's okay with everyone, but if anybody does have any problems with that, if you just drop us an email at the contact details we've provided at the end, we'll pick that up later. As you'll see, the webinar is structured around a slide pack. This is a much shorter version of the slide packs that were made available in advance of the webinar, and we will make this slide pack available to everyone as well on the webpage straight after the webinar. You should have a menu down the right-hand side of your screen. We've got a version in our slide pack here. You can see you should have yours over on the right-hand side. We recommend that you don't minimize the menu. You'll see we have, but that's to make the slides easier. Please don't minimize your menu, because that means you can see who's on the call under the attendees list, and it also means you can access the chat section. That allows you to read the questions people are posting or comments, and also to write your own if you wish. We've set the chat to everyone, so everyone can see the questions that people are typing. If by any chance your to box at the bottom of your chat block is not set to everyone, if you set it to everyone now, that will hopefully make that work. So please do write your comments or questions as we go along. Also, if you have any issues at all with the webinar, just write them too, and we'll try and pick up any practical stuff just as we go. But in particular, we're allowing breaks, short breaks for discussion between the main sections of our presentation. So if you would like your question to actually be, if you would like to ask your question verbally in those breaks, if you could just add a note to your question that says, please can I have an opportunity to ask this? And then we will look for that. And basically when we get to that point, invite you to speak and unmute your mic for you, so you don't need to worry about your mic. If we don't get any audible questions, we'll select one or two or some themes from what's coming through and pick up some of those with the group as we go along. Again, apologies in advance if we find there are so many people wanting to speak that we can't select more than one or two of you, but just to say that after the webinar is over, we're going to collate all the questions and post responses and comments in response to those on a document on our website. So everything everybody tries to engage with today will mean that we are able to respond to you, we hope. Hopefully that explains everything that you need to know to participate in the webinar today. But just post a question on chat if you have a problem, and we'll try to sort it out for you as we go along. Just before I move on, the content of the webinar is just shown to you on the left of the slide. This is what we're planning to cover. We've got 3 breaks for discussion in between the main sections, and each section will be presented by a different member of the team who will have a photograph and an introduction to themselves just before they start. It's my job to keep everyone to time, so I better do my own section in a timely fashion, and I may need to interrupt a section or a discussion section just to move us along. We just want to start by acknowledging our funding from the Health Foundation on the Advancing Applied Analytics programme. So thank you, Health Foundation, for allowing us and supporting us to do this piece of work. We'd also like to acknowledge Imperial College partners for allowing us to use their Tableau server, which has also been enormously useful, so thank you for that. hopefully everybody has had a chance to read the background information that we've provided, which explains what our project is about and what we've been trying to achieve. But in very brief summary, we are a team that specialises in healthcare quality measurement, and we wanted to engage with clinicians so that we could understand much better what they want from the data that we provide. In particular, we wanted to try out converting 3 of our existing NEQOS reports into an interactive data visual software format, and to get clinicians involved in helping us to do this to try to meet their needs. We've worked on all 3 of the products shown on this slide, and we've provided links to 2 of those for you, the hip and knee dashboard and the mortality report, in advance, just to be able to give you a little bit of a taster of what we've been doing. So again, hopefully people have had a chance to read what we have been, how we've approached this task, but just this slide illustrates all of the steps that we've taken, and in very, very brief summary, along with doing some rapid pragmatic literature reviews, doing an option appraisal on which tools to use, or engaging a local digital design company to help us. We've essentially focused on a creative approach to engaging clinicians in our region through pragmatic focus groups and interviews embedded within regional meetings, for example, or local meetings. And then ultimately, we also organised drop-in events that were actually at clinical sites to try to get feedback from clinicians on the prototypes that we developed for further feedback and development. So the whole aim of this has been to develop, to understand clinician requirements, and then to also try to extract from everything we've done a set of more generic design principles that we think do apply to data visualization tools that in particular we want to share with colleagues today. So the aim of today's webinar,
can we just
take a pause? It sounds like we might have a technical issue, colleagues.
So for some reason the slides are not showing on screen.
Okay, so we're moving the slides along. So yes, bear with us 1 second.
Okay.
Thank you very much, and apologies. I could see the body language in the room that something wasn't quite right, but I was ploughing on regardless. So what I will just quickly do, I'm not going to spend any time on them, but just so that you can see what the slides had been. The slide about the structure of the webinar, what we're covering, thanks to the Health Foundation and to Imperial College partners, our aims of our project, a diagram of how we've approached the task, which all of this will be available after the webinar as well, and where we had just got to when colleagues had intervened so effectively, the aim of today's webinar. So the aim of today's webinar is particularly to share with you the lessons we've learned from clinicians on how they engage with our development of interactive data visualization tools, and the first draft design principles that we've devised as a result of the work. And in particular, we're really keen on your feedback on these, because we're going to develop them further after the webinar and we'll make them available. And we do also have a couple of slides before we finish to just share some of the practical tools, just a couple of practical lessons from developing the interactive dashboard. So with no further ado, I am now going to hand over to Tony, who seems to know how to control the slides, Tony Roberts, who's going to talk to you about clinician requirements.
Right, thank you, Paula, and hopefully everybody can see the slides okay now, and it's getting good audio as well. So I'm Deputy Director for the North East Quality Observatory, and also I'm Deputy Director at South Tees, which is the acute provider in Middlesbrough, and I'm the Patient Safety Lead for the North East and North Cumbria. So I've been involved in measurement, particularly around quality and safety for a long time, and so this is obviously an important topic from my point of view. What I'm going to do is explain the 5 categories that we've developed out of the feedback that we've had from clinicians, and actually what we found is that was irrespective of their specialty. So the orthopedics and maternity clinicians, as well as those involved in mortality monitoring, had the same sorts of issues. And you can see what they are there: accessibility, levels of interactivity, visual displays, and the layout and navigation of the tool, its content, and also the outputs. And I'm going to go through those in a little bit of detail now. So in terms of accessibility, people made the point that they need to be able to log in as easily as possible. People don't like having multiple passwords to remember, and it needs to be as straightforward as possible. They would like it to be completely public, but there'll be lots of situations where we can't do that, but logging in is a key issue. We also heard that they need to be able to download and print out, so that if they're in a position where they can't log into the web for some reason, for example, people mentioned being on a train and so forth, they can still have a version that they can get to, that they can download in advance to review. The second area was around levels of interactivity. They definitely want to be able to benchmark, and they want to be able to choose the benchmarking groups that they have access to. They don't want that to be fixed all the time, and it might change from metric to metric. They definitely want to be able to deep dive and ask their own questions. The point of an interactive tool is that they're not stuck with just the pre-analyzed metrics that we might think are most useful to them. They want that ability to choose their own way of interrogating the system. The third area of comments were around visual display and layout and navigation. Obviously, they want that to be as simple and as clear and as intuitive as possible. They particularly mentioned the inclusion of text. So NEQOS is well known in its current tools for the text that interpret what the graphs and data displays show, and they didn't want to lose that in moving to an interactive system. Now, clearly that produces challenges because you can't always react to the selections they've made, but nevertheless, they wanted as much text as possible. They're also keen to have an at-a-glance version. So particularly for the busy executive end of the spectrum, people want to know what's the key messages coming from this dashboard. You know, they might not always have time to do all the delving that they might do on other occasions. In terms of content, there was a lot of discussion about the timeliness, and this is an issue that I think will come up later in the webinar as well. Because of the nature of the data that we often present, it's not as timely as the clinicians really want, and they emphasise that. They're also keen that metrics that have become out of date, either because organisations have merged or because the metrics have been changed, then it may not be relevant, and that may, even though it might be perfectly valid data that's available in the data set, they might want to taking out because it's not current. They're also keen to have some sort of alerting system so that if they're going to a dashboard on multiple occasions, they can quickly see what's changed for their organisation, which metrics have gone up or down, that sort of thing, without having to plough through the whole lot. In terms of outputs, they're keen to be able to create their own bespoke outputs. We were encouraged to keep static outputs as well. We had thought that maybe the interactive tool would completely replace the sort of PDF and PowerPoint based static tools that we currently produce, but people were really clear that they wanted both. They also made the point that they need to be able to extract data out of the data visualization tool and insert it into their own presentations and reports. And that's got to be really easy. They don't want advanced IT skills in order to be able to do that. But a lot of the time, the data from the tool will only be part of a report or a presentation, not the whole thing. So they need to be able to extract the bits that they want. I think these two comments that we picked out of the drop-in sessions give you a feel for the sorts of things people were saying. You know, so static reports are helpful when you're short of time, but dynamic reports are good when you've got more time to delve into the data and figure out which things you want to look at. They also talked about the time pressures, so it's got to be quick and intuitive. Lots of trusts have IT limitations, so you've got to be able to overcome them. They need to be able to log into it easily. They want familiarity, so they want a consistent look so that it feels normal and it wants to look like the NEQOS reports they're used to, and their ability to explore the data. So I think they're the key things that came from the clinicians.
Okay. Thank you very much, Tony. Thank you. So that's, as I say, a summary of the, actually, Tony, if you could just maximise the menu as well, please, at the top. Thank you. and repost the slide pack. This is obviously going to be an ongoing thing there. Obviously, so this is a distillation of a longer PowerPoint slide pack that, for those is available on the web page that you were able to access and will still be available to you after today. But hopefully that's given you some highlights, and particularly the groupings. So I'm just turning to Valerie, who's watching the chat room, to see if we've got any particular questions on this section.
We haven't had any questions yet, but recently we presented at an event, and one of the questions that came up was whether any of the clinicians were different to what we would have expected. And perhaps Tony would like to answer.
Okay, so I think in large part they were on the sorts of topic areas that we expected, but some of the emphasis was a little bit different. So I think we did think that static reports would disappear as we moved to interactive, and it was really clear that people wanted to be able to keep the reports that they're used to. So that was a little bit different. And what was the other thing? Oh yeah, the issue around the timeliness of the data was much more strongly expressed, and I think since we've done this work, we've realised that actually what people most want is data coming out of EPRs and systems of that sort. So that's really, really live data, which is a bit different to the work that we normally do in NEQOS, where we're generally using aggregated benchmark data. But the clinicians nevertheless said, what I really want to do is see the data that's coming out of my practice immediately. So that was another key issue.
Thank you, Tony. Have we any? Actually, could I just? This is Paula again. Could I just make a quick comment to follow up Tony's point about real-time data? Because one of the points that came across really strongly to me in the drop-in events was that we use in NEQOS, we often use national audit data because we're looking, for example, at the detail of how a particular NICE guideline recommendation has been operationalized or been delivered. And you often need national audit data to actually be able to get to that level of detail. And one of the things that did come across to us from the clinicians, that their relevant national audits, even though they are the most relevant for them, were still issues about timeliness and how long the time cycle is from contributing data to getting your reports, and for us using the benchmark data to be able to use it. So it's just to emphasize that really strong message coming out. I'm sure all of our colleagues across the country will recognize this. So
if I could mention, so I think because they know that they're submitting the data to the audit, they want to be able to see their own internal data before submission somehow alongside the nationally released data, and that's a really interesting issue, difficult to solve, but this is what clinicians said.
Thank you. So we've just had a question from I can see on the chat from Martin. I don't know, Martin's not Martin Barsley from the Health Foundation, not identifying that you want to ask it verbally, Martin, but let us know if you do. But his question, if you can see it, is: did clinicians have a view on use of statistical tests of differences? I'm going to just I look around my colleagues. I am not aware of any discussion on this in any of the events I was in, but I just want to check with colleagues. Tony.
So in the orthopedics work and the mortality work particularly, we use funnel plots and statistical process control charts through time of the sort of making data count type people will be familiar with. And so there's that element of statistical analysis going on, and people are keen on that, and they kind of take that as read from NEQOS reports. But of the sort of, let's have a t-test for difference type of thing, no, I don't think anybody mentioned it. It's not high on a clinician's list of things that they want.
Yes, and I wonder how much, given the funnel plot example or statistical process control example, they work with us, they're expecting us to have thought about this for them to some degree. But so there's what I think there's a Valerie, I think there may be another question in that we've got time to deal with before we finish this slot.
Right, Lynn McVeigh has asked a question. Have you any thoughts on how to assure quality of the data if you use live data from EPRs?
Yes, and pointing out, yes, that national clinical audits validate data, and one reason why the data takes time to produce.
Yeah, it's an absolutely key issue, isn't it? That, you know, often the data that is most real time isn't validated and might be telling you something completely wrong. So I think, as I said, I think it's a really difficult one to solve. I understand why clinicians want very timely data, and also why analysts might think that's not an entirely brilliant idea. All we can tell you is that's what clinicians say, and you need to think about ways of solving it. I don't know, we might, I think different audits do it in different ways. So if I think of the NELA audit, for example, the National Emergency Laparotomy Audit, we've got locked cases and unlocked cases, so you could have a choice about which ones you're seeing, that sort of facility. And I also think you could do quite a bit about saying, you know, putting, if you like, health warnings on the data to say, look, this is the provisional data, this is what's going on. You can use it for helping you check that the data is accurate and so forth, but don't assume it is before you start. If you want the finalised, proper, validated version, you'll have to wait until you get the national outputs.
Thank you, Tony. So I think just for time, I'm going to just draw this. I don't think we've got anything outstanding just at the moment on the questions. I'm just going to draw this discussion slot to a close, but just one, again, Paula, one additional comment that I had noted going back to the were we surprised. The other thing that we explicitly asked about when we first went out to see clinicians was about which medium they were using to access this sort of tool. And we were surprised that there wasn't a strong demand for us to make the tools available, certainly on phones. Practically everybody acknowledged that they would not be able to get the detail that they needed on a mobile phone screen. And even on tablets, most people were happy with a format that worked with a laptop. So again, that was a little bit surprising. It was something we went out to anticipate, and that obviously was helpful to us in terms of working out how we needed to go forward. So I will thank you very much, everybody, for your questions, and thank you to Tony and Valerie for picking up some of those. I'm going to move us on now to Lucy, who's going to talk to us about our first draft of design principles.
Hi, so my name's Lucy Lindsay. I'm one of the health information analysts at NEQOS, and I thought I'd run you through the draft design principles as we currently have them. So as you can see, we have 10 principles, so these are them just in summary. And I thought I'd go through them one by one. So the first principle is regarding end user engagement. We found that you really need the clinicians to be involved in how a dashboard is set up. It means that the functionality works how a clinician would use it. We realized that we as analysts have our own opinions and maybe our idea of how a dashboard would look. By having the end users involved, it means that the design is tailored to both a clinical environment and it functions as a clinician would use it. And obviously once you have that, it increases the acceptability. The second principle we have is to be clear about the actual clinical question. We now collect a vast amount of data on a daily basis from various sources. You know, when you use Oyster Card in the morning, it knows where you're going and where you've been. And it's possible to have a problem with the noise around your signal. So you actually have so much data, you're not clearly answering the question. Obviously, this is a big issue for our clinicians. So we want to be able to see what's going on. We want to be able to answer the question that they've asked. We can obviously use follow-up questions. I mean, ultimately, a good dashboard should filter the noise and so that the signal is easier to find. So the third is that the data should be as up-to-date as possible. And as Tony alluded to, there was a big issue about timely data. Quality of care should be based on the most relevant recent data. And that's one of the issues we had with what was relevant. Clinicians may feel that some data is too old to provide useful insights. As we said, our work is based on publicly available data and often on audits. And when we did some work with maternity, we were told that data that was 2 years old was too old. However, the Embrace dataset looking at stillbirths published the 2017 data in October 2019. So it actually was already 2 years old at publication. So the fourth one is ease of use. To ensure that the dashboard is self-explanatory and doesn't require a user manual, it should be plug and play. In our setting, we've done this using hovers to explain how something works, with separate explanations of what the data is telling us. We need to be cognizant of what visual data principles already exist. So a caveat to this is not a full review of generic visual design principles. It's very much limited to the group level data for quality and audit purposes. We found that there needs to be a balance between visual complexity and information utility. We also found that there was simple things like colors have an underlying meaning. So whether you intended or not, something in red will be seen as stop or a hazard, something green will be seen as good or passable. There needed to be consistency. So it needed to be consistency across the screen, so the screen looks homogeneous across the dashboard, but also to a degree of branding, so between dashboards, similar color schemes. Functionality matters, so if a button works one way on one viz, the same button in a same place on another viz will seem to have exactly the same function. We ultimately have had a crash course in psychological principles of design. So things like PARC, so proximity, alignment, repetition, and contrast. We found that the human brain will fill in blanks in an image, making relationships whether they exist or not. So we had to look into things like Gestalt, so looking into principles of visual perception. You'll see a man in the moon when we all know there isn't one there. So there's some general visual design principles we've had to have a think about. So number 6 is to ensure that the tool is easy to navigate. It obviously needs to be clear. As we've alluded to, the clinician needs and thoughts are often different to the analysts or to the designers, and how they navigate through a dashboard matters. It has to be clear and easy for them to find, and easy for them to understand where any links or data is if it's going away from the dashboard. So number 7, to ensure that selections made within the dashboard are retained. We have this in 2 sort of sections. The first is just the simple thing of holding. If you're looking at a trust on the first visualization of a dashboard, you still want to be looking at that same trust 3 visualizations later. It needs to hold that selection. And then similarly, we need to be able to save queries. If you are looking at something and your trust in particular is an outlier in January, you would like to be able to run exactly the same question in February and in March and in May to see whether or not there is any positive or negative progress. So to make sure that there isn't any variation in exactly what the question is being asked or confusion through that, it's helpful if that query itself can be saved and retained within the system. So the 8th one, to ensure that the dashboard has capacity for the outputs to be extracted. The clinicians made it very clear that they use a lot of the graphs from the NEQOS products in their own presentations, and therefore the layout of the charts needs to be conducive to extraction from the dashboard. So although we've discussed narration, that needs to not be on the text on the graph at all. There should be no text overlapping so that the graph can be moved and used in somebody else's own presentation. So as we said, there was an indication for narrative explanations. These come in a variety of forms, either how a metric is defined, what the data itself is showing, or even a summary statement of what's happening in the area to date. The clinicians still wanted these. However, too much text on a visualization means you can't actually see the graph clearly. And so we have to make sure that you don't obscure the graph, and you have a way of making sure that the information and interpretation is present. In this sense, we have used explanatory text for methods on hovers or collapsible menus. And when there needs to be more data or more information, we've used something like metadata, so setting them out on, say, Google Docs, so they're away from the main site. It's important to not have clutter. So the last design principle is that there is a role for both the interactive and static products. This is in part because of IT issues and security and firewalls in the trust, but then equally because people have talked about using them on trains and things where you would rather have a static product. So ultimately, the static is good for a quick lookup, and dynamic is better for deep diving or further investigations. So hopefully that'll give you a rough idea of our design principles, and obviously we're welcome to discuss them further or have some suggestions to changes. Thank you.
Thank you, Lucy. So we're taking another short break now to give a chance for some discussion. So firstly, I'm just turning to Valerie to see if we've got anybody who would like to speak or any additional questions. Not so far on the chat. So I'm going to, can I prompt?
Can you open the chat back up?
Yes, so I think I saw that, but Valerie will read it for
There's a
us.
question from Javier. Did you consider accessibility, i.e. screen readers, as part of your design principles?
Yes. So I'll let Lucy start on that one, and I think we might have some particular additional things to feed back in from our design company as well, who had some input on this.
Yeah, so thank you. We didn't think about things like screen readers when we started this. We have tried to make things as clear as possible, and as Paula alluded to, we have had involvement of an external digital design company who have given us some feedback on font sizes and things like that to make things clearer. We'll admit that this was designed for clinicians, and there was a degree of assumption that some of the clinicians would not require screen readers and similar things, so we hadn't set them up to start with, but it is something we could look at in the future.
Thank you, Lucy. And so it was definitely something that came up as part of our process, and we are debating and how much that balance between an essentially technical audience for much of what we're talking about here and really important recognised accessibility principles. But thank you for that question. What I'm just going to I'm going to prompt a couple of questions to the chat room. I'm going to prompt them anyway, and then we'll pick up this one in case anybody, and again, we can pick them up afterwards. It doesn't have to be now. Yes, we're ready for that. But firstly, I'll prompt them in case I can prompt a bit more. The first one is, if you think, just from your own experience of your own work, there's any obvious principles missing that you think you have generated from work that you've been involved in, and or if there's any particular principles that you think are very relevant to what you do and you wanted to make a comment on how that might work in your sector. So they were just two questions that I'm planting for as we go on through the webinar, but now I'm going to turn to Valerie for the question that's just come in.
Yeah, we have another question from Martin Barnsley from the Health Foundation. Do you think you could use your 10 points as a way to audit or assess a range of existing visualizations used across the NHS? Examples of good, bad practice might be interesting, question mark.
Very interesting question, Martin. Thank you. I'm going to start with Tony on that one, just to have a think about whether this might work, but also Valerie too, just to have a little think about this. Because obviously one of the clear issues for us is impact of the work we've done and how we try to disseminate an impact on. This is one potential way of doing that.
Yeah, I think it's a really good idea. And I think you could turn these into I'm not sure if an audit would be the right term, but certainly a self-assessment. You could make a tool for people to use to self-assess their stuff, and I suppose you could be kind and do it to them and audit it in that way. But I think it's a really good suggestion. And it's not something that we've done so far, I don't think, but we definitely could think about that. So yeah, good idea.
And we could think about it in our more than we're doing currently, probably in our own NEQOS products. I mean, this has obviously raised awareness. amongst the team, and we are trying to incorporate that into products as we're going forward. But more of that is definitely required.
Yes, so that part of our local learning, isn't it? Part of our own team learning is making sure that we generalise this to all the work that we do. I guess one just additional quick thing to say is that we are aware that the draft design principles are principles, but they're at quite a high level. What we haven't tried to do is to make them more detailed into a sort of a guideline, or so if you've got a principle, as was picked up earlier, about accessibility or say font size or whatever, we haven't then said it needs to be whatever it needs to be. So we weren't intending to do that, but if something like this was to be built into a tool, you might want to take it further to some degree, because then you'd have more specific criteria that people can then actually use. So there's something about how you would take it forward to that level, and we are aware we're at that quite high level at the moment.
Yeah, I also think that one of the things we learned was that the 3 examples that we use, so maternity, mortality and orthopedics, they even though we tried to achieve a certain amount of design consistency between the visualizations, actually because of the nature of the data, it was really difficult to have a single way of doing it. So I actually think orthopedics and mortality were the closest, because they did both have funnel plots and trend lines and kind of bar charts and stuff, but the maternity data was pretty different in the way it was set up and the kind of output it produced, if you like. So it was really difficult to make that visually similar. So I think it would be difficult to be really specific. I think you have to stay at a kind of principles level, because it depends such a lot on the data you're trying to present, how you actually do it.
Thank you, Tony. Does anybody else on the team want to comment on this one before I take the next question? Thank you. So just, Valerie, there's any further questions? Not just at the moment. So one of the things that I wanted to come back to, just again to share with colleagues on the call who may be able to respond to us after the call or on the chat line. As we've said, we got it very strongly through our clinician requirements exercise and have translated into a draft design principle, is this issue of including interpretive text. So as I think Tony started off earlier saying that one of the things we do in NEQOS that is maybe a little bit different to other analytical teams locally is that we provide reports essentially with interpretation around them. And so one of the challenges we were already aware of before we started was, were we going to need to try to do that as part of the tools? And clearly we've got it back as a requirement only for the things that need interpretation. If it's obvious, we would hope that people will be able to find a way around it. And as Lucy very helpfully described, we are coming up with ways of trying to do it. But it's maybe one, again, just to plant for our participants today, that given the different functions everybody has, how much other bodies are thinking. Obviously, if you produce a report like a national audit, that's very different. But if you are a body that is itself trying to produce an interactive tool, the sorts of things that are now online through Model Hospital and NHS Improvement, etc., is what you are thinking about in terms of the need, or if you recognise the need to include interpretive text and how you will do it. So I'm really just planting that one, and if anybody has a response to that, that would be really interesting to pick up on the chat line or after today. At that point, though, I'm looking to my left because I can see there is a question around the draft maternity dashboard. Now, I'll just say something briefly about this, but I think probably in general, I've got a closing comment later about what happens next with the dashboard. So perhaps I'll refer you to that in general. But in the meantime, yes, the only reason we didn't provide a link to the draft maternity dashboard in advance was A, we thought the 2 that we made available illustrated all the points we wanted to talk about today. And B, there were a number of things that we're still trying to just sort out on that dashboard. But right at the end of our comments, I will just say something about the dashboards going forward and what happens next. So I hope that's okay for the moment in terms of that one. Just looking again to Valerie, is there anything else that's come through at the moment?
No, nothing at the moment.
And then I guess I'm going to just ask my own team just one more question before we move on to our next section. I love this actually, being able to ask my own team all these different questions. Of the design principles that we've got there, did anybody find or a requirement that they would think is particularly key, or that maybe is particularly changing the way you look at things going forward? Does anybody have something they'd like to pick up there?
Just tease that out a little bit more for me.
So of all the 10 draft design principles, again, perhaps could we just put the slide back again, just to put them, is there any of those that really, obviously we put them all forward, but is there anything that you just really stands out? I suppose I've made my point about interpretive text, that's one of the ones that I've made. Yeah. But is there anything else that you or any of the colleagues would pick up?
I think the hardest one to solve is this business about being up to date. And I think it's a key one from the clinicians. It's key to their engagement, but it's for some of the reasons we've already talked about around data quality, etc. It's the hardest one to solve, I think.
Yeah. Okay. Thank you, Tony.
There's a bit of discussion going on as well on the chat about which one we went for. And as Valerie's just posted, we did use Tableau, and we did spend quite a bit of time trying to work out which one to do. I don't know if we're covering that in a bit, but
Giles Foster from NHS Digital has asked a question about that. What were the considerations around the different tools available? Power BI, ClickView, Tableau. What were the deciding factors, and what was the chosen product, which we've answered? Tableau.
Yes. So for today, I'm just wondering if I might just ask, Kyung has got a little bit about that because she was going to cover it in her next slides, but I'll just invite Kyung to say a little bit. But we did conduct quite a detailed option appraisal when we first started the work. And again, we can provide more detail of that and how we approached it as part of our response on the website after the webinar's finished. But in the meantime, it's a lovely opportunity to ask Kyung to say a little bit about that before I invite her to start her presentation. So in terms of just choice of tools, Kyung.
Yeah, so we have assessed, I'm going to cover next.
Okay, would you rather?
Yeah,
okay, yes, I'm just conversing with Kyung across the table, and I think she'll pick this issue up as part of her slides in just a second. Yes. So I hope that's okay with everybody. Is there anything else that on the chat line, anything else anybody in the team just wants to highlight at this point about design principles? So thank you very much. But again, I would just encourage everybody participating, if you've got any other ideas, any feedback, any additional ones we're missing, or just particular areas that you'd like to think more about, then please do email us after the webinar, and we'll capture it in a further draft of these design principles going forward. So at that point, I'm going to now hand over to Kyung, who will bring up her picture slide just to introduce herself. And if you could also minimize the menu, Kyung, thank you. For Kyung is going to just talk a little bit about some of the more practical lessons, particularly using Tableau. Over to you, Kyung.
Hello, my name is Kyung Goff, and I would like to present for about 5 minutes or so what key lessons we have learned from the tool development. So first point is user experience design is challenging without specialist skills or training, and it requires time. So conducting insightful user interview is one of the keys to a successful product. So for the best practice for user interview, we can summarize to 3 points. So first, ask good questions. Make sure the questions are clear, open-ended, and focus on the topics you are investigating. Second, choose a few topics. On average, plan to discuss 3 to 5 topics during the focus group. And third, include the right amount of people. A focus group should include 3 to 6 users, large enough to include a variety of perspectives, but small enough so everyone has a chance to speak. Second point is how time-consuming and difficult it would be to choose data visualization software. So we have considered R Shiny, Power BI, and Tableau. And Shine is a brilliant open source tool. However, at the time when we were considering our choice of tools, staff hadn't been trained in R, so we felt that moving away from Excel to completely open source might be a risk not be able to deliver the prototype in time. Therefore, we were making decisions between Tableau and Power BI, as national bodies like NHS Digital and NHS Improvement use them widely. So we have assessed between two data visualization tools using criteria such as ease of use for analyst teams and analytical capability and license cost. And Power BI and Tableau, they have a pros and cons. They kind of cover all the our criteria elements, but one of the key factor was a license fee. And then we would like to thank again to Imperial College Healthcare Partnership, as they kindly let us use their server space for this project. The next point is Tableau is a great tool, we found. However, one key lesson we learned is that Tableau is not a full-fledged application development tool. Navigation in Tableau can be particularly tricky, we found. And so when digital design company reviewed the prototype, they suggested to build an HTML, CSS web application prototype with embedded Tableau visualization. We also found that sometimes it is not straightforward to achieve things in Tableau. So we've quickly learned that all the complicated data processing and statistical calculation is better to be done in R or Excel formulas, and use Tableau for the nice and looking visualization. So during the development, I just picked some examples of what I mean by can be quite not be straightforward. The one example is a funnel plot. So as you can see in the left-hand side of the template, in order to create a funnel plot in Tableau, we had to use rather unusually structured Excel template. And the other example is a tooltip. So when working long text in Tableau from Excel or Microsoft Access, Tableau automatically trim the text longer than certain number of characters. So therefore, text has to divide into multiple columns before importing into Tableau. So I want to say the key lesson from here is that if you develop in Tableau, give more time to think about, because you often have to come up with a workaround solution in Tableau development. Thank you very much.
Thank you, Kyung. So they were just a couple of tasters. I should probably say again that obviously, as we picked up to some degree the question earlier, we needed to select a tool to work on. Obviously, what we're trying to do is produce some more generic principles that work, whichever tool you're using, to actually think about data visualization, interactive data visualization. But we did think people might be interested in some of those particular tasters about the development process. So we have an opportunity to pick up any questions or comments again now, both in response to what Kyung was talking about, but also it's our last chance for any verbal discussion within the webinar format today. So if yes, so okay, we just seen a question. Kyung is dying to answer it. So
yes,
we'll pick up this. But as I say, just before we start that, just to say this is a chance we've got about 5 minutes if people do have any further comments, and also if anybody does want us to unmute their microphone, we'd be very happy to do so. So we've just had a question in, Valerie.
Yes, another question from Martin Bardsley at the Hout Foundation. If you could start over again, would you have picked R or other open source option?
So Kyung, dying to answer this.
I would say yes. And because when we started year and a bit ago, the R was kind of new. I mean, for myself, it was kind of new. But over the years, I have myself through NHSR community and also my own interest, developed more interest in this open source path. So definitely I can see the much benefits and the advantage. So yes, is definitely yes. We would consider the open source approach. Probably R Shiny. Is that?
Yes,
Yeah.
thank you. And of course, it would be very interesting now
Yeah.
for us to engage with colleagues who are using R Shiny
Yes.
in terms of our principles and how easily they can be operationalized, but we obviously don't know the answer to that. I think we have another question related to...
We have another question related to R from Tom Lawrence. You noted that you were processing in R. Are you doing that using the integrated function within Tableau or externally processing in R and then importing? And I'll go to Yong again for an answer to that.
Yes, we are processing in R externally, and then creating, all the process is done in R, and then export as a CSV file, and then put into Tableau. That is how. So Tableau is kind of end of visualization, nice looking, because yeah. Does it answer the question? Yes.
I think it does, but again, if people have, obviously we'll do the headline questions today, and if there's more detail, we can follow it up. So that's great. I think we had another separate question from Chloe.
Yeah. So shall I pick that one up? What do you think of the advantages of Power BI over Tableau or vice versa? I think I'd make a couple of points here. One is how difficult it is to compare them. So I don't know if this is deliberately by the companies, but figuring out the difference in cost is difficult. Working out the difference in functionality is not straightforward. One of the reasons, just going back to cost for a second, is that Power BI is a Microsoft tool, so it depends what other Microsoft tools you've got in your organisation. We sit as hosted within 2 NHS Foundation trusts, so that makes a difference to what they want to charge you and so forth. And it's not just the license costs and the software, if you like, it's also what hardware. Are you going to have to run it on a server? We managed to crack this, as we've talked about, because Imperial were already doing it and solved some of these problems, and we were able to piggyback. But it's a key decision, and it's actually really difficult to do. And even though we engaged with people selling both of the products, it was still really difficult to make a clear judgment about which was best. At some point, you have to clump and just decide, this is our best guess at this point, which one's going to be best, and go with it. Because the other key element, which I just mentioned, is of course you've got no idea really how the development's going to go. So one might be better than the other at a particular point in time, but they both claim to be developing at a fair rate of knots and changing. So how much do you want to try and future-proof yourself? It's a key problem, and a really difficult one to solve.
Thank you, Tony. Valerie wants to just come in on this one, and then just looking at my very careful timekeeping, I am then going to close the discussion section, and obviously again encourage people. I've got a few closing comments to make before hopefully everybody will still be with us. But Valerie, you wanted to just add to Tony's comment.
Just to add to Tony's comment, particularly around pricing. We found the pricing was more transparent with Tableau than with Power BI, and also within Tableau, a lot of the functionality that we required in terms of the types of charts we wanted to be able to do seemed to be integrated more within Tableau, or at least with Power BI, they said that's a custom visual and you may have to pay for it. So we had a set budget and we needed to know what our costs were going to be up front, and we didn't want to find them escalating as we went through the project, having to pay for custom visuals that perhaps we thought were within Power BI. Now I know Power BI has been rapidly developing in the years since we chose Tableau. So a lot of the reasons for discounting Power BI may have now disappeared since we started the project.
Yes, and I should also, just to close that, also comment, obviously our experience has been with Tableau as well. We should be really clear about that in terms of the project. So we're only limited to the appraisal we made at the beginning. So I'm going to thank you very much to everybody for your comments and questions. I can see there are more coming in, so as I mentioned before, we will be able to respond to those after the recording. What I'd like to do now is just to essentially wrap up, because we are absolutely determined to let you go on time today.
Can we just pick up one?
Oh, right. This is what happens, isn't it, when I'm trying to chair, Tony? Go on, you're going to have to be very quick indeed.
There's a question from Tom about whether we lose the interactivity because we're processing outside of R. I think Kyung's answer is no. We've kept...
Because interactivity is happening in tablet.
Yeah, so provided all the base data is there, you can still say, actually, I want this benchmark, not that. I want this time period, not that, etc. So you don't lose that.
So thank you for picking that up. And obviously, please do. We would encourage ongoing dialogue if there's more detail that people would like. So if there are further comments or questions, please, you can quickly type them on the chat while I'm doing my last 2 minutes, or please do email us at the address that we're here. We're really keen to engage with colleagues who've been on the call today to further some of this work. Any questions not addressed today, as I've mentioned, will be answered on the webpage. We'll probably do a summary document and post them all together. We will post this slide pack on the webpage, just in case that's useful to have the shorter version. We will also post the recording, which is still going now, but I will be stopping in just a minute. In terms of the 2 dashboards that you've been able to have a look at, the link to the 2 dashboards will stay open until the end of this week, i.e. close of play on Friday. Which I think is the 29th? Yes, close of play on Friday. Please, if you're interested in what happens next with them, please do email us afterwards, because obviously we've got a relationship with our own local trust, but also we're just very interested in how we might be able to take some of this work forward. We will also be updating the draft design principles if we get any further feedback. So again, please encourage you to email us about those if you've got any comments. We'll then update those and put them back up on our webpage. So it just remains for me to say an enormous thank you for everybody who's participating, and I can see some very kind thank yous popping up on the chat, so thank you to you too for your thank yous. To say an enormous thank you for everybody, to thank again the Health Foundation for allowing us to do this work with their funding. I will now go through a process that closes the meeting, and wanted to thank you all again, but I'm just going to say goodbye from us, and you'll see us stop the recording, mute the mic and exit the meeting. So thank you everybody.